Dear friend, dear patient, and dear colleague, today is my pleasure to have the next lecture on a very, very important topic, which is by the through not a gynecological topic, even if we are talking from a gynecological disease, the endometriosis, because diagnosis and treatment of endometriosis of the sciatic nerve is neurosurgery. It's not a gynecology. So let's start with some generality about the endometriosis and the understanding of the endometriosis of the sciatic nerve, what it is. First, I have to mention that when I start with this pathology, it was 2004. I remember exactly the first time I performed a laparoscopy for an endometriosis of the sciatic nerve. It was awful for me this day because I was not trained to perform surgery like an endometriosis of the sciatic nerve. I was trained in gynecology, in advanced endometrial surgery, and in oncology, but I was not trained in neurosurgery to the pelvic nerves. Definitively not. And I remember that 2, 3 years later, when I present my first series of, I think at that time it was 5, 6 cases of endometriosis of the sciatic nerve. It was on the Congress of the American Society of Laparoscopy, the AGL. I remember that everybody told me, Marc Possover, you're crazy. You're crazy because you do a surgery and patient will go home sitting in a wheelchair. First information. Even if you have a destruction of the sciatic nerve is not in charge of the walking function. If you have a lesion of the nerve, the patient will present some trouble of the locomotion, of the walking function, but will never sit in a wheelchair. The second, all the colleagues said at that time, Mr. Possover, sorry, but endometriosis of the sciatic nerve don't exist. We have endometriosis of the uterus, the ovarian, the bowel, whatever, but of the sciatic nerve, never see in my life, it don't exist. So at that time, I was considered as a crazy guy. By the way, today it's exactly the contrary. Everybody seems to find endometriosis of the sciatic nerve, and we see more and more video on endometriosis of the sciatic nerve on international congress. But I will come back on this special topic at the end. So the endometriosis of the sciatic nerve. Endometriosis, you know, is a condition where tissue similar to the lining of the uterus grow outside the uterus. So you can find endometriosis of the ovarian, the tube, to the appendix, the diaphragm, everywhere, the bladder, the rectum, the ureter, everywhere. And you can also find some endometriosis outside the abdominal cavity, what we call the retroperitoneal or deep endometriosis. And the most common of this kind of endometriosis are your endometriosis of the ureter. But endometriosis of the nerve is much, much more certain, especially endometriosis of the sciatic nerve, because the sciatic nerve is the most far nerve from the intra-abdominal cavity. It's really very, very deep outside the abdominal cavity at the level of the pelvic side wall. So, endometriosis of the sciatic nerve, it's an endometriosis that affects the sciatic nerve. And we'll come later on my lecture, even if the name is endometriosis, like endometriosis of the ovarian, the uterus, the ureter, all these issues on the same name, endometriosis, but by the truth are not the same disease. You cannot compare an endometriosis of the sciatic nerve with an endometriosis of the pelvic organ. So for the sciatic nerve is the biggest nerve from the whole body. It starts from the lower back, emerge first from the spinal cord with what we call sacral nerve roots. The fusion of the sacral nerve roots together builds the sciatic nerve and the pudendal nerve and the bladder for the voiding function of the bladder and the rectum. And then the sciatic nerve will leave the pelvic cavity and go inside the buttock and then down into the leg. And endometriosis can affect this nerve and induce a huge neuropathic pain. So the prevalence and incidence, once again, prevalence is how many cases exist, and incidence, how many new cases per year. So prevalence and incidence of endometriosis is well known, even if in the literature we're talking from 10%. In my opinion, this is much more than that. But prevalence and incidence of the sciatic nerve, there are no data. There are no data because the sciatic nerve is within the pelvic cavity. Neurosurgeons are not doing surgery within the pelvic cavity. Neurosurgeons sometimes perform surgery for endometriosis of the sciatic nerve, but outside the pelvic cavity at the level of the buttock. The problem is this surgery will fail because the endometriosis develop within the bladder, the pelvic cavity. So if you do surgery on the nerve from outside, you will miss a big part of the endometriosis within the abdominal cavity, the pelvic cavity. So endometriosis surgery of the sciatic nerve is not a classical neurosurgical procedure coming from outside. For that, you need laparoscopy, and neurosurgeons are not trained in laparoscopic pelvic surgery. And gynecologists are not trained to surgery to the pelvic nerve, are not neurosurgeons. And for this reason, it's more or less you have no data on prevalence and incidence on the endometriosis of the sciatic nerve. Of course, I have the biggest series in the world. I have more than 500 endometriosis of the sciatic nerve where I performed surgery, but it took more than 20 years of my life to have 500 patients. And why so much? Because over the last 20 years, nobody else was doing endometriosis of surgery for endometriosis sciatic nerve, even more because most of the gynecology didn't believe that endometriosis of the sciatic nerve exists. And even if it's a main congress, actually, a lot of colleagues are coming with, I'm doing surgery for the endometriosis of the sciatic nerve, because then you are a star in the gynecology. Sorry, but most of the gynecologists will never see an endometriosis of the sciatic nerve in their life, and of course will never be trained enough to do such kind of surgery. So clear data don't exist. The symptom, you have pain, neuropathic pain, that means burning pain, tingling, electrical shock, starting from the lower back, passing down along the buttock and down to the leg, the dorsal aspect of the leg. The pain is not radiating in the front of the leg, always dorsally. Once you have lesion of the nerve, the patient will develop sensoric disorder, mean numbness, and weakness in the legs. She will develop a muscle atrophy from the gluteal muscle, buttock, and the calf muscle. And of course, when you have a loss of the muscle, the patient will develop a gait disorder, walking, standing difficulty, with two main symptoms. One is a foot drop, and the second one is a Treadle-and-Burr gait, which are typical for deeply infiltrating endometriosis of the sciatic nerve with starting destruction of the sciatic nerve. So how the endometriosis of the sciatic nerve is diagnosed? By the way, to have the suspicion of an endometriosis of the sciatic nerve, you need clearly a neuropelveological evaluation. It's not a gynecological evaluation. You need the knowledge of the examination of the pelvic nerve. That is a neuropelveology. You will never reach an endometriosis of the sciatic nerve by the vaginal examination. Our fingers are much too short. Secondly, you will never reach an endometriosis of the sciatic nerve by the vaginal sonography. And in MRI, the radiologist will see an endometriosis of the sciatic nerve if he is aware that endometriosis of the sciatic nerve does exist. And endometriosis start usually with few cells. And I found in some cases patients with endometrial spot in the middle of the sciatic nerve, from 1 to 2 millimeters in diameter. If you do MRI, especially outside the menstruation period, you will not see anything in MRI, even more when the radiologist is not trained in this pathology. So if you want to confirm that you're suffering from endometriosis of the sciatic nerve, you need a laparoscopy, because only taking tissue from the sciatic nerve and bringing it to the pathologist under the microscope will give the confirmation, yes, it is an endometriosis of the sciatic nerve and not something different. So, factor, yes, there are some risk factors. Because we don't know exactly, but risk factor, yes, because endometriosis of the sciatic nerve has nothing to do with metastasis of endometrial cell from the uterus to the sciatic nerve. Uterus and sciatic nerve, nothing in common between both. You cannot have endometrial cell going to the sciatic nerve through blood vessel or lymph vessel. No, endometriosis of the sciatic nerve obviously develop within the sciatic nerve. One theory I proposed for 2-3 years was the hypothesis of mature cells within the sciatic nerve, which under epigenetic factor start for some reason to develop an endometriosis within the sciatic nerve. And risk factor obviously are hypermobility joint syndrome or Ehlers-Danlos syndrome, because most of my patients with endometriosis sciatic nerve are coming from countries like India and Iran. And if you see in the literature, you will find that in this population, the incidence and prevalence of Ehlers-Danlos syndrome is very high. Simply look how people are sitting for hours on the floor. It's very difficult for us to sit that long because we have not such an elasticity of the joint like a woman in this country. So Ehlers-Danlos could be a risk factor. Then treatment. Treatment, if you want to treat an endometriosis with of the sciatic nerve with hormone, forget it. Hormonal treatment will never treat an endometriosis of the sciatic nerve. It will maybe slow down a little bit the evolution of the endometriosis, but it will never treat. So trying to treat it with hormonal treatment, for sure the endometriosis will start to destroy the nerve, and at some point you will lose the mobility or part of your leg. The only way to make a diagnosis and to treat endometriosis of the sciatic nerve is the laparoscopy. You have to go there. You cannot do that by open surgery because you need microsurgery. You need magnification on everything. And you cannot bring a microscope within the pelvic cavity by open surgery. While the laparoscopy, the endoscopic surgery, is per se a microsurgery, a microscopic device, because you have a magnification from everything up to 10 times. So laparoscopy, and you have to resect the endometriosis. And when the endometriosis already start to grow within the nerve, this endometriosis already start to destroy part of the nerve. And you have to resect this part of the nerve in order to avoid the recurrence. It's so simple like that. You cannot go a second time or a third time there. When you have an endometrium from the ovarian, from the bowel, whatever, if you have a recurrence, you can do 2, 3, 5, 6, 10 laparoscopy. But the sciatic nerve, in each laparoscopy, you will develop scar tissue. And every scar tissue, due to your procedure, will make every second surgery much more difficult, much more dangerous. And as a surgeon, you will be not able to recognize if the scar tissue is because of the endometriosis, and in this case, you have to remove this scar tissue, or it's because of the previous surgery. In such situation, it's no need to remove the scar tissue. So, several neuropelveological considerations on this disease. The first is that isolated endometriosis does exist. If you see here, 2007, I make a paper on 3 patients where I perform a laparoscopy by suspicion of endometriosis of the sciatic nerve. And in these 3 patients, I didn't find any endometriosis within the pelvic cavity. No endometrioma, no adenomyosis, nothing. I was sure that the patient is affected by endometriosis of the sciatic nerve. I went there. By the way, you cannot just go to the sciatic nerve to check if it could be. You need really a strong indication to say, yes, I have a high suspicion of endometriosis of the sciatic nerve. I will go there. Otherwise, it's not allowed to just go to the sciatic nerve and to check in case. That is too dangerous and with too high risk of secondary complication and morbidity. So that was 2007. And now, if you see on the paper on the left, it was for 2 years. I report on 267 patients with isolated endometriosis of the sciatic nerve. So it seems obviously that the endometriosis of the sciatic nerve start to develop within the sciatic nerve and don't grow from the uterus, from the rectum, or from somewhere and to reach secondary the sciatic nerve. Most of the endometriosis of the sciatic nerve develop directly at the sciatic nerve. The second consideration, and for that we got the prize from the European Society of Gynecology for 2 years, for this paper on 267, because this paper focused on 20 years of my work. It took me 20 years once again to get 500 patients. And in these 500 patients, I had 267 with isolated endometriosis. And what you see here on the left, that was a patient with a small spot from 1 millimeter, less than 1 millimeter to the sciatic nerve. For that, you can do 10 MRI per day, CT scan, whatever. You will never see that on the picture. On the right side, the patient have a severe neurological disorder because the endometriosis already destroyed 1/3 of the sciatic nerve. And the question in this paper was to know, are that two different diseases or one is the same disease but a different stage of the development of this disease? And the answer is clear, that is the second option. So this kind of small endometriosis from less than 1 millimeters, if you don't do anything, after 1, 2, 3 years, the patient will start to develop neurological disorder and the endometriosis will start to destroy the sciatic nerve. So endometriosis of the sciatic nerve is not like an endometriosis of the ovarian, the uterus, of the rectum. It grows and that's it and retracts the tissue around. No, endometriosis of the sciatic nerve is not a cancer, clearly not, but like a cancer, will destroy the sciatic nerve. That means when you have high suspicion of endometriosis of the sciatic nerve, you have to go there. You have to be trained to go there, but you have to go there. And even if MRI is negative, sonography is negative, and you don't find anything by the laparoscopic inspection of the pelvic cavity, if during your neuropelveological diagnosis, you're sure that it's an endometriosis of the sciatic nerve, or at least you have a very high suspicion, then you go there. And sometimes you have even sometimes a situation where you have to open the sciatic nerve to check inside if you will not find there the endometriosis. And to do that, it's not enough to just say, oh, you have pain in the leg and in the back once a month during men's bleeding. It's an endometriosis of the sciatic nerve. Let's go. No, that is not neuropelveology. That is gynecology adapted to the nerve. It's a gynecologist who want to do something to the nerve, but that is not a neuropelveology. And it's exactly like a neurosurgeon. A neurosurgeon will never open your brain to check what is going on in your brain without having a clear indication and a clear diagnosis. And endometriosis is exactly the same. Endometriosis of the sciatic nerve. Then the next considered neuropelveological condition is there are two types of endometriosis of the pelvic nerve. What is the endometriosis of the sciatic nerve, which is a very destructive disease, and there is another one is the endometriosis of the sacral plexus. That means the roots which build together the sciatic nerve. But the endometriosis of the sacral plexus is not an endometriosis that develops at the sacral plexus. It's an endometriosis from the uterus of what we call the rectovaginal space, which will grow laterally and will reach at some point the sacral nerve roots. And this kind of endometriosis usually, mostly surrounds the nerve, but don't destroy the nerve. And the endometriosis, the sciatic nerve, once again, start his development within the sciatic nerve and will destroy the sciatic nerve over time. So, sciatic nerve surgery consideration, and that is probably my main message. Surgery for sciatic nerve endometriosis is definitively one, if not the most difficult and dangerous pelvic surgery. You can kill a patient if you're not trained in this surgery because of bleeding. Bleeding, you have a lot of blood vessels surrounding the sciatic nerve. And if you're not trained in vascular surgery and in neurosurgery, you have a high risk to induce unnecessary damage to the sciatic nerve. And if you get a bleeding and you are not trained in vascular surgery, you can even lose your patient. So, moreover, the surgeon have only one chance. It's a single shot surgery. It's exactly what I said before. Due to your surgery, you will induce some scar tissue, fibrosis. And if you start and at some point you're becoming afraid, you stop the procedure, you will make the surgery for the next surgeon much, much more difficult and much more dangerous. And you cannot perform incomplete surgery. When you're there, you have to resect the whole endometriosis at the sciatic nerve because it's a single shot operation. You cannot go there once again, a second time, a third time in case of recurrence. That is unacceptable. So a surgeon will never learn overnight to perform this kind of surgery. You cannot decide, oh, I'm a specialist in endometriosis surgery in oncology, and up tomorrow I will do surgery on the sciatic nerve. No, it took me 20 years of my life to be trained in this surgery. So you need for this surgery a neuropelveologist, a certified neuropelveology, ISO level 3, and that is not enough. These neuropelveologists need years of experience in this field. Now, once again, even if I have a lot of cases, it's not because there is a lot of endometriosis of the sciatic nerve around the world, but because over 20 years of my life, nobody else was doing this surgery. I was the only gynecologist in the world doing laparoscopic surgery for endometriosis of sciatic nerve. Once again, this kind of surgery is not a gynecological procedure. It's a neurosurgery on the sciatic nerve with huge vascular consideration because that is the main danger. And in a lot of cases of endometriosis of the sciatic nerve, because the ureter is very close to the sciatic nerve, you will have to do something with the ureter, resection, reanastomosis, or even reimplantation. So that is really the highest level of surgery in the pelvic cavity. So, endometriosis of the sciatic nerve is once again very rare, but it's manageable with proper care. And if you are looking for a surgeon that to tell you, yes, I'm trained in endometriosis of the sciatic surgery of the endometriosis of the sciatic nerve, I have experience, there is a simple thing. Check under what we call PubMed. Here you have a link. You go on the link, you give the name of your surgeon, and you will see how many publications he wrote on neuropelveology and on surgery of the sciatic for endometriosis of the sciatic nerve. Don't check if he is a good endometriosis surgeon or good oncology. Probably yes, but endometriosis of the sciatic nerve, once again, is not gynecologic surgery. It's not gynecologic endometriosis or oncologic surgery. So there you can check, because you cannot do such kind of surgery without medical and scientific evidence, mean without making publication on that. And then that is my personal remark. Sciatic nerve endometriosis is currently becoming a trend in gynecology. More and more on the Congress and on the social media, I see colleagues showing, look, I'm doing endometriosis of the sciatic nerve. But this surgery is not a show. This surgery is very, very dangerous. It's really, you need experience, otherwise you will lose your patient. There are increasing number of videos on social media showing casing surgery for sciatic nerve endometriosis. And with more than 20-year experience in field, in most of these videos, I often see no endometriosis. I'm missing the disease. I see video with nice dissection of everything, but I don't see endometriosis. And then the question is, it was really an endometriosis of the sciatic nerve or just a nice dissection, which you could train on cadaver. And the secondly, what I see is at some point, a lot of gynecologists stop the procedure because they are becoming afraid. They have not the courage to remove the endometriosis from the sciatic nerve because they are not neurosurgeon. And concerning the ISO certification, yes, we have a level 2 workshop certification in endometriosis, and I teach the colleague the treatment, the diagnosis and treatment of endometriosis of the sciatic nerve, but it's a 3-day workshop. You will never learn in 3 days how to do this kind of surgery and how to do the diagnosis. The ISO level 2 workshop don't give the right to say, I'm a neuropelveologist. It gives you the right to start to become a neuropelveologist. But you're far away from being an endometriosis, a neuropelveologist, and even more far to be being a neuropelveologist specialized in endometriosis of the sciatic nerve. So I thank you very much for your attention. I hope it was not too much information. Stay healthy, be happy, and see you by the next education video on the next neuropelveologic topics. Thank you very much once again. Bye-bye. Good evening.